Welcome back. We're going to take a look at the rest of the heart here and start off by looking at the cardiac cycle itself. And so the heart, we alluded to back in the talking about the blood moving through and the valves closing. We talked a little bit about systole and diastole. And so when we refer to the cardiac cycle, we have periods of contraction, and this is referred to as systole. And then when the heart muscle is relaxing, we have diastole. And so this is going to occur there in the relaxation point of the heart itself. The heart can be looked at in a couple of different aspects as far as the control of the heart goes. And so we have the heart when it is filling, we have the heart when it is contracting, and we have the heart when it is emptying. And so ventricular filling itself is occurring while the heart is effectively relaxed. And so the heart is in a period of time where the heart is in a low pressure state. The valves going from the atria to the ventricles are open, and the atria are starting to go through their systole, so their contraction, and blood is starting to fill those ventricles. We're going to have a moment of time after that where the ventricles are filled and they're going to start to contract. And as the ventricles begin to contract, the pressure inside of the ventricles leads to the closure of those AV valves. And so basically, as pressure increases inside the ventricle, that's going to push back on the cusps of our tricuspid and bicuspid valve and close those valves up. Once those valves are closed, we still have the semilunar valves closed. Now we have the AV valves closed, and contraction is occurring. This is going to lead us into isovolumetric contraction. In other words, we have contraction without any change in the volume inside of the ventricles. So the ventricles are contracting, but they're not getting rid of any of the blood that is inside there. Instead, they're building pressure. And that pressure is going to build and build and build until the pressure inside the ventricle becomes greater than that in the semilunar valves. And so ventricular ejection begins once we've risen above the pressure inside the aorta and above the pressure inside the pulmonary trunk to blow open those semilunar valves. And then the volume is going to start to decrease, and we have ejection of the blood. And now we're going to go into a period of time where the ventricles are relaxing. They're no longer contracting. So we're in ventricular relaxation. Blood pushing back because we now have a high pressure inside the aorta. We have a high pressure inside the pulmonary trunk and a low pressure inside the ventricles. So the blood wants to move from the aorta and the pulmonary trunk back into the ventricles. That's going to lead to the closure of the semilunar valves. Now those semilunar valves are starting to decrease, or I'm sorry, it's starting to close, and the blood is pushing into them, and the pressure is decreasing inside those vessels as well. But for a moment, if we were just to look at the pressure inside our aorta there, the aortic pressure goes up, and then it starts to fall, and at essentially this point here, the pressure is to the point where now the ventricular pressure is decreasing, and we're going to see a little notch. This is what's referred to as the dicrotic notch. And so this dicrotic notch is when the actual valves close. So the blood comes into the semilunar valves, and as it does so, it causes the pressure to blip up just a little bit. And so the blood, we kind of draw a vessel here, and then we'll draw our valve there. So the blood was coming this way, and it went through the valve, and once that valve closes and the blood starts to push back against that valve, that's where we see that little dicrotic notch. The pressure goes up for just a moment inside the aorta itself. And we can see that over here on this image here where we have that dicrotic notch. And so the green line there is the amount of pressure that is inside the aorta itself. And so that's our aortic pressure inside there. And the pressure rises as the ventricle contracts. It then starts to fall off a little bit. We get that closure of the valve. And as that valve closes, we then get this little dicrotic notch here. The pressure goes back up momentarily, and then it continues to fall and fall and fall until we get to right in here or so. So it's going to fall down, and then the next contraction is going to cause it to go up again, and then we get another dicrotic notch from there as well. And so depending upon when those valves are opening and closing, determines where that pressure change is. And so here we have the aortic and pulmonary valves are closed. That occurs right at this point here in terms of that closure of the valves themselves. And that's where we see that pressure start to rebound back up as the valves have now closed and the pressure rebuilds inside the aorta itself. The amount of blood that the heart is ejecting with each contraction, if we were to measure that amount over the course of a minute, we would get what we call cardiac output. And so cardiac output itself is the amount of blood pumped by the ventricles in 1 minute. And so with each contraction, we're going to get so much blood coming out of the ventricle. And so that amount of blood that is released with every contraction is what we call the stroke volume. And so since we're going to do it over the course of a minute, or we're going to measure it over the course of a minute, we're going to also need the heart rate. So cardiac output equals heart rate times stroke volume. And so in order to calculate that, we'll need to know what the stroke volume is, and then we'll also need to know what the heart rate is. And from there, we can get our cardiac output. So the heart rate is just simply the number of contractions or the number of beats in a particular minute. The stroke volume is the amount of blood actually ejected from the ventricle with each contraction that is there. And that's going to allow us to calculate what our cardiac output is. That number is going to have kind of our baseline, and then we're going to have an extra amount of cardiac output that we can have, and that extra amount from our baseline, which is rest, to our maximal cardiac output is the amount that's in between there and there is our cardiac reserve. And so the cardiac reserve is the amount of extra cardiac output that we have on there. And this is going to be dependent a little bit on age and fitness of the individual themselves. So a while back, we said that normal heart rate, we were going to call at 75 beats per minute. And so that's where the heart rate is kind of sitting at, so to speak. And then for the stroke volume, we have 70 milliliters. And so when you think about it, your heart's only about as big as your hand. And with each contraction, you're going to get 70 milliliters being ejected from the heart every time it goes out. And 70 milliliters is actually quite a fair amount of blood that's there. Imagine a graduated cylinder. A large one is typically 100 milliliters. And so you're filling that up to the 70 milliliter mark there on that particular graduated cylinder. So we have a fair amount of liquid that's there coming out of the heart with each contraction itself. And that's going to vary a little bit from person to person. So if we calculate that, we're going to have 75 times 70, and that's going to get us to a whopping 5,250 milliliters per minute, or 5.25 liters per minute. And the significance there is, if we remember back to when we talked about blood, is that our blood volume was roughly on average about 5 liters. And so we have the equivalent of roughly the entire blood volume that we have going through the heart every single minute. Stroke volume isn't something that we can very easily measure. So we can't just go up to a person and determine what their stroke volume is, in a sense, just kind of by looking at them or measuring something from the outside of their body easily. So in order to truly understand what that stroke volume is, stroke volume is going to be determined by the difference between when we filled the heart and then when we emptied the heart, and how much is left afterwards in there. And so we have a couple of volumes that we need to understand. And so stroke volume, which is what we've been talking about, is the difference between our end diastolic volume and the end systolic volume. And so end diastolic volume was ventricular filling. So during diastole, we're filling the heart. And then end systolic volume is after systole. This is after we've contracted the heart and the blood has gone up. So our diastolic volume is going to be larger than our systolic volume. So end diastolic volume is going to be bigger than end systolic volume. So we come up with a stroke volume there for our heart itself, which is then again going to be roughly 70 milliliters. Things that can affect stroke volume are the things that are working kind of against getting the blood either into or out of the heart itself. And so when we look at the heart, we can kind of think about the heart as being kind of something similar to that of a balloon. So we've got kind of an oddly shaped balloon. And when we fill the heart, that balloon gets bigger. The amount of pressure that we put on it, or the amount of stress that is on the walls themselves, is what we refer to as preload. And so it's how much we stretch it out. It's kind of like blowing up a regular balloon. And so if we blow up a balloon and blow it up just a little bit and then let it go, it flies around for just a little bit. It maybe just goes a little bit and then it's done. But if we blow that balloon up more, get it more inflated and let it go, it's going to fly around all over the room. Our preload that we had put on it, the amount of stretch that we gave to the walls of that balloon, was much greater. And so the preload is essentially what's going to tell us about how hard we need to contract the heart. The other side of the coin, in a sense, is the afterload. And so the afterload doesn't really have a whole lot to do with the heart itself or its filling or anything like that. It actually has to do more so with the vessels coming off of it. And there's my drawing of the aorta and the pulmonary trunk there. And so primarily we're more concerned with the aorta. So there's our aorta coming off of the heart. And as that aorta comes off of the heart, there's blood inside the aorta. And that blood has pressure. And in order for our ventricle, our heart, to get the blood to go up and in through that semilunar valve, push it into the aorta itself, we've got to work against the pressure that's already inside there. And so if we think about kind of what we deem normal blood pressure, 120 over 80, the 80 number, our diastolic number, is the amount of pressure that generally the heart is going to have to overcome in order to get the blood to come into the aorta. So the ventricles are going to have to squeeze in with enough force in order to overcome that diastolic pressure. In the process, they're going to go from that 80 up to 120 inside there, and then the 120 is going to come back down to 80. But the afterload is the amount of pressure that is inside that aorta that the ventricle basically has to get above in order to have that contraction or that ejection to occur. The preload side of things relates back to what we call the Frank-Starling law. And so Frank-Starling law relates to the amount of stretch that's in the cardiac muscles themselves. And so the greater the amount of stretch that is there, the greater the strength of the contraction is going to be. And so if we fill up the heart, in order to get back to, in a sense, kind of the baseline volume that we had, we have to increase the contraction that is there. We only have the same amount of time basically to do the contraction. So the more that we have preload, the more stretch that's there, the greater the strength of the contraction is going to be. And so things like a slow heartbeat can increase the amount of venous return that's coming back to the heart and then increase our stroke volume. Exercise can do the same thing as we start to increase the amount of blood that's returning back from our muscles as we're kind of pushing it back towards the heart itself. That's going to lead to more preload, which is going to increase our stroke volume. If we lose blood, so if we have some sort of blood loss that's occurring, we have less blood in the system to bring back. You've been losing it along the way. The heart's pumping it out and less of it comes back to the heart. That's going to decrease stroke volume. At the same time, if we increase our heart rate to a very high rate, that means that we have less time for actual filling of the heart. And so if we only have, in a sense, if our heart rate is 60, we have, to a certain degree, kind of half of a second at least or more to have filling of the heart. If we double that to 120, we've now got half the time. If we triple it up to 180, we've got a third of the time that we have to actually fill the heart, which means that a extremely rapid heartbeat can be very inefficient to the actual contractile process itself because stroke volume is going to decrease. So on the left here, we have our preload. And so as we push out on those ventricles, the ventricle stretches out, it becomes pushed even further in a sense, and that's going to dictate how much that heart is going to contract. What's the strength of that contraction that's there? From there, we then have a certain volume of blood that's inside the ventricle there, and it needs to be able to contract hard enough in order to get the blood to leave the ventricle. It's got to overcome that pressure that may be inside the aorta or the pulmonary trunk. And so if the pressure inside the ventricle can only get to, say, 75, it's not going to be able to get any blood out. It has to be able to get the pressure above 80, and even in a sense 81, to start the process of opening that valve. And then it's going to push the blood into it. And then eventually it's going to raise that pressure inside here upwards towards 120. Other things can influence stroke volume as well. And so it's not just the preload and the afterload. We talked before that we have innervation to the heart itself. And so things like our sympathetic nervous system can increase the contractility of the heart. And so this is going to be the same effect as increasing preload or afterload. That's there. And so we can increase that contractile strength that we get from having the sympathetics kick in. The same thing essentially happens when the adrenals do the same thing by releasing hormones. And so things like epinephrine, norepinephrine are going to have that effect on the heart as well. Other things, excess amounts of calcium that we have within the body as well is going to potentially increase those levels as well. The stroke volume itself can be decreased when we have other things going on in the body as well. And so one of which can be a situation where we have, say, an acidosis, and so our pH is dropping in the body. This can be from a metabolic source. So we could be having a situation where something is happening inside the body on a metabolic level that is causing the pH to start to decline fairly rapidly. We can change the ion concentrations. And so things like potassium and calcium can alter the stroke volume and the contractility of the heart itself as well. And so increased amounts of potassium, so again, we may have something like a kidney problem that's going on inside the body that's going to decrease the contractility of the heart. If you wanted, in a sense, the heart to be able to rest, we may use a calcium channel blocker. And so a calcium channel blocker is going to block the receptors for calcium so that it doesn't have the ability to cause that contraction like it normally would. In the increased stroke volume side of things, we said that we have the sympathetic nervous system. And so the sympathetic nervous system, through sympathetic stimulation, is going to cause the release of our neurotransmitter norepinephrine. That norepinephrine then comes to the heart and it binds to a beta-1 adrenergic receptor. That beta-1 adrenergic receptor is going to initiate a second messenger response, and that's going to lead us to the second messenger cyclic AMP. Inside the heart now, so the norepinephrine does not come across the membrane. It's simply working with our G protein linked receptor that is there, and that's going to lead to the production of our cyclic AMP. Cyclic AMP then serves as a catalyst to activate protein kinases. So we start to get protein kinases that are becoming increased in terms of their activity, and that's going to lead to more calcium becoming bound to troponin. And troponin is kind of the key to our muscle contraction, and that's going to then lead to our increased heart contractile force as well as the speed of the contraction itself. And so our heart rate's going to go up and our contractile force is going to go up, thereby in the end raising things like our heart rate, raising our cardiac output, potentially raising our blood pressure, all in the same process. Things that do change heart rate can do so either in a positive way or in a negative way. And so any process that increases the heart rate, so this could be something like sympathetic stimulation, is going to be a positive chronotropic factor. Anything that decreases the heart rate is going to be a negative chronotropic factor. And again, kind of the opposite there, we could have the parasympathetic nervous system doing that for us as well. The sympathetic nervous system is always wanting to increase heart rate. So that's our fight or flight side of things that are there. And so that's going to increase when we have what we would want to be times of stress in general. And so these are the things that are going to generally raise our sympathetic activity, generally stress, potentially anxiety, excitement about something in general, whether it be a good thing, a bad thing, etc., and even exercise. All of those are going to lead to an increased heart rate, which then increases our cardiac output as well. The parasympathetic side is always going to be working against the sympathetic nervous system, and so it's always going to be opposing it and trying to keep it down. The majority of the time, we are under parasympathetic control. So our parasympathetic nervous system dominates the autonomic regulation of the heart itself. It's keeping the heart rate lower. So if we left the heart, in a sense, kind of on its own, our heart rate, rather than being 75 beats per minute, would be more like 100 beats per minute. But that sympathetic tone that we have, and more so because it's coming down from the vagus nerve, our cranial nerve, the vagus nerve, it is going to keep our heart rate lowered down as much as 25 beats per minute, versus if we turn off that vagal tone. Next up, we have the atrial reflex, or the atrial Bainbridge reflex. This is a sympathetic response that occurs when we have more venous return. And so we've got an increase in the blood that's in the atria themselves. And so our atrial volume has increased. This is going to stretch out the cells inside the atria and leads to the SA node firing off. And so the more return that we have, this is essentially going to stimulate the SA node to fire more. And so inside the atria itself, there are pressure receptors called baroreceptors. And this increases the nervous system on the sympathetic side to increase. We've got more blood coming back. We may be doing some sort of activity, things like that, that has increased that blood return to the heart and increasing what's going on inside the atria themselves. The heart can also be controlled on a hormonal level. And so we talked a little bit about this when we talked about the endocrine system itself. And so we talked about epinephrine and also our thyroid hormone, so our thyroxine that is there, both of which increase heart rate. And so if a person's heart rate is elevated, it may well be because of something like thyroxine being elevated, our thyroid hormone being elevated. And so if there's no other good reason, in a sense, for it to be there, it's one thing to start to look at as far as a person's hormone levels go, is to look at the amount of thyroid hormone that they do have within the body itself. Other things that can affect things as well are the different ions. So we talked a little bit about potassium just a little bit ago. So we have things like potassium, sodium, and calcium levels themselves all having an effect on the heart's normal function. And so if we're elevated in one or depressed in another, that can then lead to the potential for changing the heart's contraction. So when it comes to cardiac output, it's not just an easy thing to say that cardiac output equals stroke volume times heart rate. In the end, yes, that's what it is. And so it's the stroke volume that we have times the heart rate. But both of those are influenced by many different factors. Some of them are positive, and some of them are negative in terms of their response within the body itself. And so we can have things that turn things up and things that turn things off in both the heart rate as well as the contractility, and so the amount of stroke volume that we have as well. And so many different factors can feed into that all throughout our day, depending upon what's happening at any given moment within the day itself as well. The heart typically is going to function the way that it should all the time, but we do have certain things that end up happening to even the heart and or the rest of the body throughout one's lifespan. And some of those things that can occur are in the blood vessels that supply the heart. So we can have coronary atherosclerosis, and so the blood vessels that supply the heart. We talked about this way back at the beginning in terms of plaquing inside the blood vessels, leading to a limited supply of blood to the heart muscle itself. If the heart has to work harder all the time because the person has high blood pressure, that's going to increase that afterload. And if the afterload is increased, that makes the heart work harder over time as well. If a person has had a heart attack, and so if they've had myocardial infarcts, and so this is where the blood supply was diminished or absent to a portion of the heart, it damages the heart muscle itself and makes it harder and harder for it to contract. We can have dilated cardiomyopathy as well. This is where the heart essentially becomes inflated too much over time. And all of these, that didn't turn out too well, can lead us into congestive heart failure, or CHF for short. Congestive heart failure can affect the left side of the heart, the right side of the heart, or both sides of the heart. Depending upon the side of the heart that is being affected is going to dictate, in a sense, kind of where in the system blood backs up. And so if we have right-sided heart failure, the right side of the heart receives its blood from the systemic circuit, so it's coming from the whole body itself. And if that blood can't get out of the right side of the heart and get ejected, then that's going to lead to the blood backing up into the peripheral nerve, into the peripheral system itself. And so they get peripheral edema. The edema is going to happen in their legs, in their ankles, things like that, especially. Left-sided heart failure is going to lead to pulmonary edema. The left ventricle, the left atrium, receives its blood from the lungs. And so if we can't get rid of that blood from the lungs, it's going to start to continue to back up, in a sense, into the lungs. And that's going to lead to fluid accumulation again, rather than in the legs, although it could end up in the legs as well. But it can end up as pulmonary edema. We start to get fluid buildup in and around the lungs themselves, to the point where now, not only do they have, in a sense, a cardiovascular issue, But now they also have a respiratory issue. The lungs can't inflate the way that they could because there's fluid taking up space inside the thorax. When it comes to the heart and its development, this development begins relatively early on. And so the heart chambers themselves are developed by day 25. They originate from 4 different major components. We have the sinus venosus, the atrium, the ventricle, and the bulbus cordus. Each one of those are going to, in a sense, have a fate that takes them into a different portion of the heart itself. And so in the first days of life of the embryo, we have, rather than a heart, we have what we call endocardial tubes. Essentially, these are tubes that contract, and they're going to be able to cause blood to flow along the system and into the other vessels themselves. But shortly after that occurs, those 2 endocardial tubes begin to fuse to one another. And so with it, we have the changes that occur to the different areas themselves. And so we have the yellow up here is our bulbus cordus. We have the red area is the ventricle that is there. And then we have our sinus venosus down here in blue as well. And so those areas that are there for the sinus venosus, and then the atrium kind of in that area there as the junction between the two. So those are the primitive areas that we have, and those different areas are going to kind of start to change as they move along through this process. Not only do those tubes fuse to one another, but they're also going to twist on one another. And so they're going to start to twist back and forth on one another. And as they do so, they start to form the 4 chambers that we end up with in the heart itself, as well as the major vessels that supply and, in a sense, drain the heart also. And so the bulbus cordus is eventually going to lead us down to things like our major vessels that leave the heart. And so we have our aorta, we have our pulmonary trunk that are leaving the heart itself. The ventricles conveniently become the ventricles. And so those are becoming the primarily all of the ventricles themselves. The atria become the atria on both sides there and continue into those components there. And then we have the sinus venosus, which are going to contribute part of the vena cava. There's a superior and an inferior vena cava, as well as part of the atrium as well. Slightly different picture, but same concept in terms of the twisting and the turning of all of the different portions of the heart. And this is happening in a very short amount of time. Everything has to be very well coordinated, or else we may end up with a heart defect. And so if things don't happen to the exact moment in the exact time, then we may start to have some issues there with the development of the heart, many of which oftentimes don't really become a problem until after birth. So fetal heart defects are relatively common within live births themselves. Some of them aren't going to really become a problem until after birth whatsoever. And both of these here are those that are going to be there for the normal bypassing of pulmonary circulation. So when a fetus is inside the uterus, there's no need for it to really send blood over to the lungs to exchange gases. There's no gas there. There's no ability to exchange the gases. So we have 2 structures that are going to allow for that bypassing. One is the foramen ovale, and the other one is ductus arteriosus. And so the foramen ovale connects our 2 atria. It's essentially a hole that runs between the right atrium and the left atrium to get blood to go from the right atrium over to the left atrium. The next bypass that we have is in the pulmonary trunk, and we have the ductus arteriosus. The ductus arteriosus bypasses blood from going to the lungs by connecting the pulmonary trunk to the aorta. And so it allows for some of the blood that is coming out of the right side of the heart heading up towards the pulmonary trunk, out towards the lungs, it allows for some of that blood to bypass and go directly into the aorta. Because remember, in terms of fetal circulation, there's no gas exchange, so there's no need to go to the lungs. All of the oxygenated blood is coming from the placenta. So there's no need for that exchange of gases to happen there inside the lungs whatsoever. If those structures don't close off after birth the way they're supposed to, then where we start to have the problems. And so I'm going to jump down to the bottom of the list here. And so our foraminal valley becomes a depression in the wall of the atria called the fossa ovalis. And so this becomes that opening that's there. If we have a patent foraminal valley, that means that now unoxygenated blood from the right atrium is going to mix over into the left atrium and vice versa. The ductus arteriosus, which normally connected the pulmonary trunk up to the aorta, needs to close off shortly after birth as well. And they both normally do. And so the ductus arteriosus is going to become the ligamentum arteriosum. So when a blood vessel closes off, it becomes a ligament after that point. And again, somebody can have a patent ductus arteriosus, which means now that unoxygenated blood that was headed towards the lungs is now mixing into the aorta. We're sending unoxygenated blood over to the systemic side of the circulation. And we don't want that. We're now mixing with either one of these, oxygenated and unoxygenated blood, and that's not the point of the heart. It's meant to keep the two separate from one another. That's there. Depending upon the severity of these defects, can dictate kind of when the problems start to arise. And so this here, the arrow there is pointing towards the patent ductus arteriosus. And so we're looking at basically the top of the heart. We have coming in here that patent ductus arteriosus there. From there, we have the aorta over here and the pulmonary trunk coming here. So that normally allows us to bypass the two and allow that blood to move from the trunk over to the aorta during the fetal stages. This may stay relatively small. It may be very large and the problem is noted early on, or it may not be really something that's there or noticed until the infant starts to really kind of move around a lot. They start to become more mobile on those. So some other defects that can occur as well. We have ventricular septal defects. So this is similar to the foraminal valley defect in a sense, where we have a patent one. This one is occurring in the ventricular wall, and this is going to push blood from that left ventricle in towards the right ventricle. And so we're putting oxygenated blood back in towards the deoxygenated side of the system. The aorta itself can become pinched, and this is what's referred to as coarctation. And so that coarctation makes it so that that part of the aorta is clamped down, almost like somebody's squeezing it, and that makes the ventricle work harder. And so we get an increase in the afterload that the heart needs to work against. The last one here is tetralogy of Fallot, and tetralogy of Fallot is 4 defects that are occurring to the heart itself. We have the same ventricular septal defect that we had before, and so that lies within the heart itself. The pulmonary trunk is narrowed, and so since that is narrowed, that then leads to hypertrophy of the right ventricle. And so we get a right ventricular hypertrophy, which makes the right ventricle now strong, and oftentimes even stronger than the left ventricle, which means that we pump deoxygenated blood, just erase those, going over to the left side. So we have blood that's meant for the lungs is coming back over onto that left side on that part there. And so we start to see these changes happening within the heart itself. All of them will typically require some sort of surgery in order to correct it. This one here is a septal defect. You can see in the middle here, this is the actual septum. And in that septum, we have a hole in the septum itself, which is allowing the blood to move back across from the left ventricle over to the right. And here is a interventricular septal defect. We can see the hole in the ventricle themselves. We can see here the chordae tendineae that is attached there. And in this picture here, it has been fixed. And so the opening there, that space that was there, has now been closed and is no longer going to allow for blood to cross over to the other side. This is the patent ductus arteriosus. And so the arrow there is pointing to the PDA, or the patent ductus arteriosus. There's dye coming into the heart there within the pulmonary artery. And once they clamp it and stop that blood flow, now once that dye comes in, it doesn't instantly come across. It's going to move through and go through the lungs and then end up coming through the entire system the normal way that it should as it makes its way through. Another ductus arteriosus that is patent as well. Sometimes the patent ductus arteriosus can be there for decades, and a person doesn't necessarily know that they have occurred there until something else happens that can sometimes cause things like blood clotting. So back when we talked about the blood, we said that anytime that we slow or make turbulent blood flow, we have the potential to cause the heart or the blood to form clots. And that can be sometimes those symptoms that come there from the PDA being there for a long time. Other age-related effects that change the heart itself over time, we can have thickening of the valves themselves. So that can lead to the potential need for a valve replacement, like we talked about before. Cardiac reserve starts to go down. We don't have the same ability to increase heart rate and increase cardiac output the older that we get. Essentially, that heart rate elevation is highest when we are an infant, as far as how high we can get it to go. Sometimes the tissue of the cardiac muscle itself may become more fibrotic, and so we start to get almost like a scar tissue forming inside the heart, especially if we had any kind of damage there. And then we talked about atherosclerosis before as well, in terms of the hardening of the arteries and changing the patency, decreasing the ability of the heart to function at its normal pace. And that'll end it for the cardiovascular system.